there was a good concordance between the two.
Okay, thank you. We might move on. All right, our next speaker is Aaron, also from the Florey, and he's going to speak to us about networks in Lennox-Gastaut syndrome. Thank you.
Hello. So I'm going to be talking about some fMRI work I've been doing during my PhD in Lennox-Gastaut syndrome. So Lennox-Gastaut syndrome, or LGS, is a severe epilepsy with an onset typically in childhood. The range of possible etiologies are diverse, although patients show a very similar electroclinical profile, including generalized tonic seizures and the characteristic scalp EEG discharges of paroxysmal fast activity and slow spike and wave. Many patients with LGS show cognitive impairment with the onset of epileptic activity, and most show cognitive decline over time. And this is thought to be caused, at least in part, by intractable epileptic activity, and is a process known as epileptic encephalopathy. So while clinical observations link transient epileptic activity and persistent cognitive impairment in LGS, the mechanisms underlying this process remain very poorly understood. One framework that shows potential in exploring this relationship is the study of LGS from a network level of brain activity, both at the time of epileptic discharges and during periods without discharges. So we recently performed a simultaneous EEG fMRI in a group of patients with LGS and looked at momentary fMRI signal changes in response to paroxysmal fast activity at the top and slow spike and wave discharges at the bottom. We saw that large-scale networks of brain regions were simultaneously recruited by discharges, including specific networks that we know from previous task-based fMRI studies to be involved in normally supporting functionally distinct aspects of cognition. And in particular, we saw co-activation of regions normally involved in internally and externally oriented attention. So the rationale for this study comes from the clinical observation of epileptic encephalopathy in LGS, where transient epileptic activity causes persistently impaired cognition. And secondly, our prior EEG fMRI findings that localize this activity to large-scale cognitive networks. So here we sought to extend these findings by exploring the behavior of cognitive networks in LGS throughout the interictal state. And in particular, we aim to test the hypothesis that the functional organization of these networks is inherently abnormal, and that the abnormal organization persists during periods with and without epileptic activity. So we studied 15 patients with established LGS with a mean age of 28 years, and we compared them to a group of 17 similarly aged healthy controls. So using a 3T MRI scanner, we acquired task-free or resting state fMRI data. And in patients with LGS, we also acquired simultaneous scalp EEG to determine periods with and without the occurrence of epileptic activity. The fMRI data underwent standard pre-processing for functional connectivity analysis. So we identified the functional brain networks in all subjects using independent components analysis, or ICA. ICA was used to separate the data into maximally independent sources of brain activity to localize networks showing spontaneous correlated changes in the fMRI signal. So a brain network can be described spatially in terms of its location in the brain, but also temporally in terms of its changes in fMRI signal over time. So using this technique, we extracted regions of 4 key networks that we previously observed to be maximally involved at the time of epileptic activity in LGS. So ICA was applied to all 32 subjects, patients and controls together. And we identified a network including intraparietal sulci and the frontal eye fields known as the dorsal attention network that we know from past task-based fMRI studies to be involved in coordinating visuospatial attention to stimuli in the external environment. We also explored a network involving the anterior cingulate and bilateral anterior insula, the assalience network that we've heard about today, that previous studies have shown to be involved in detecting behaviorally or homeostatically relevant stimuli. We extracted a network of frontoparietal regions known as the executive control network, which typically shows broad involvement in a range of goal-directed cognitive control processes, including executive function and working memory. And finally, we studied a network of medial prefrontal and posterior parietal cortex known as the default mode network, which numerous studies have shown to support internally oriented attention and self-referential thought. So having identified these networks, we assessed functional network organization by exploring the temporal interactions between networks. So to illustrate, for each pair of networks, we extracted the time course of fMRI signal change and then calculated the correlation between network time courses. We repeated this for every pair of networks to construct a functional network connectivity matrix where warm boxes indicate positive correlation between network time courses and cool boxes indicate negative correlation between networks. So some results. This matrix shows the average pattern of network interactions across the healthy control group, and we observed an expected pattern of high correlation within functionally related networks. So specifically, we saw strong positive connectivity between the dorsal and inferior aspects of the salience network, between the left and right executive control network, and between the anterior and posterior regions of the default mode network. In contrast, when we performed the same analysis in patients with LGS, we observed an unusual pattern of strong positive correlation between distinct networks, including co-fluctuations in regions of the salience, executive control, and default mode networks, consistent with an abnormal simplified network organization. So in the next part of the analysis, we performed a statistical between-group comparison of these interactions. So here we tested for network interactions showing significant connectivity differences between groups. So in this figure, I've arranged the spatial maps in a pretty circle, according to the brain network to which they belong. So first, we observed that interactions between the dorsal attention and bilateral executive control network were significantly different between groups. And here, the cool coloured lines indicate that these interactions were reduced in patients with LGS relative to controls. Patients also showed weaker interactions between the anterior and posterior regions of the default mode network and between the dorsal and inferior aspects of the salience network. Additionally, patients showed a pattern of significantly increased connectivity between functionally distinct networks. So in particular, patients showed increased, the warmer coloured lines, between regions of the default mode and salience network, the default mode and dorsal attention network, and the default mode and executive control networks. So having determined that network interactions in LGS are abnormal, we next wanted to explore whether these changes were persistent during periods with and without discharges. So for each patient, we used scalp-recorded EEG to sort the fMRI data into periods unaffected by discharges and periods affected by discharges. And then we performed a second within-sample comparison of network connectivity during discharge-affected and discharge-unaffected periods. So these matrices show the average pattern of network interactions in 6 patients in whom sufficient discharge-unaffected and discharge-affected data were acquired. We separately compared each of these periods to the healthy control group and observed a persistence of network abnormalities. However, when we compared discharge-unaffected and discharge-affected periods, our within-sample analysis revealed no significant differences. So some interpretation. In LGS, we saw abnormal interactions between large-scale networks that support key cognitive functions. Clinical observation indicates that cognition is abnormal in LGS, and here we show that networks supporting cognition are also abnormal. Our results provide a potential functional mechanism involved in the process of epileptic encephalopathy. So abnormal interactions persist during spiking and non-spiking periods, suggesting that network abnormalities are persistent. This is consistent with the observation that cognitive impairment in LGS is not confined to transient periods of epileptic activity, but rather persists across the interictal state. So our results don't, however, demonstrate a causal relationship between spiking and network interactions, and it's possible that discharges themselves disrupt network interactions, or alternatively, that the very state of abnormal interactions precedes or somehow facilitates the occurrence of epileptic activity. So network interactions show impaired integration and segregation, and this pattern shows some intriguing similarities to emerging data on the functional organization of the healthy immature brain. So emerging longitudinal studies in healthy children indicate that normal neurodevelopment is characterized by increased integration within networks and segregation between networks. Interestingly, The onset of LGS is typically in young children and is commonly associated with a plateauing of cognitive development. So the patterns we observed in this study suggest that the onset of epileptic activity may cause networks in LGS to plateau. So I'd like to thank my supervisors, John, David Abbott and Graham Jackson, as well as my colleagues in the epilepsy imaging team, particularly David Vaughan, and our collaborators at the Royal Children's Hospital led by Simon Harvey. Thank you.
Okay, thank you. Questions? Yeah, Laura.
Aaron, that was fantastic, thank you. I'm a bit naive in this area, but given what we've heard about brain stimulation and neuromodulation and these networks that are sort of abnormally correlated with each other, is there any scope for some of these areas being targets for like stimulation to try and disrupt those abnormal patterns?
For sure, and I think John's N of 1 is a patient with Lennox-Gastaut syndrome, so she's a happy recipient of that technique. So, I mean, yeah, I guess the short answer is it's not very well studied yet, but presumably you would try to somehow normalize these interactions by stimulating bits of the brain that might be involved in regulating or coordinating interactions between those networks. So, sure, yeah.
I was just wondering, with your conclusion that it looks like perhaps the network plateaued in LGS, is there any imaging in the pediatric literature that would suggest that it is arrested development, that if you image children at that age of onset, whether their networks also look like this, or is it
Yeah, so there is emerging literature in the healthy. It sounds almost like you planted that question. Yeah, there is emerging data in the pediatric neuroimaging literature. Well, this paper by Gao in 2014 longitudinally studied infants from the age of 1 month until 12 months, and they see sort of similar patterns to what we see, kind of trend towards increasing integration between long-range bits of the same network, as well as a segregation between regions belonging to different networks. So I guess it's definitely not something we can conclude based on our data alone, but it's an interesting parallel, I guess, in the literature.
I think Alan had a question. I mean, just following on from this, though, it's kind of interesting. There's also literature on altered brain states like trance. And a study that's just come out a few weeks ago on 15 shaman who they put into the scanner and they got them into a trance using rhythm.
Yep.
And what you see in these altered brain states is heightened connectivity, for example, between the default mode network and the salience network, or the default mode and the cognitive control and the salient structures. In fact, they argue that it's this that is what allows these out-of-body or altered experiences.
Right.
So I'm just making this point, I guess, to be a bit provocative, not too difficult, but to suggest that whilst this is one interpretation, and probably the more plausible, it doesn't necessarily imply an abnormality, or doesn't necessarily have to be pathological, because there are these types of states of heightened connectivity in the normal brain.
I completely agree. Like, it's not sort of the Bible in any way. It's kind of, the fact that it exists in specific states doesn't mean that it can't exist in other states that are ostensibly normal, although a trance state may or may not be very normal, who knows. Maybe it's something that sort of reflects a kind of general state. If you're persistently in that state, it's probably not very healthy. Which doesn't preclude the possibility that normal people can enter particular states of heightened connectivity. Yeah.
Okay. Any other final questions?
Aaron, do you plan to do this in our younger population with the anaesthetised data?
I would love to. The problem that we have with that data is that we don't have an appropriate control group, I guess. So we could sort of use within patient sort of variables to correlate these connectivity changes with, for example, the age of seizure onset or neuropsych profiles or something. But I guess kind of defining them as abnormal, you kind of need a reference group of some sort. I don't know whether we could use kind of like a focal patient cohort or a less severe epilepsy cohort or something like that. But yeah, for sure, like it's something I'd love to do. Yeah.
And John, I think you wanted to say something.
Sorry.
Did you have another? Did you put your hand up?
I did not put my hand up. I was just
hallucinating. Sorry. All right. Well, we might finish there and move on to the next speaker. Thank you.